Okay, so this is part 3 of pulmonary exam and rehabilitation. This one is going to focus on the therapy ed portion of the reading. Sullivan is done. Okay, physical therapy examination. Information from the patient's family, and the medical record. Acute complaint. Usually involves the loss of function, decreased ability to perform activities of daily living, or discomfort such as shortness of breath and dyspnea. Can you get up here? Get up here. Come on. She's trying to tell me the blanket was in the way. She couldn't get in her bed. Anyway, acute complaint usually involves a loss of function, decreased ability to perform activities of daily living, or discomfort, shortness of breath, dyspnea. Present illness, initial onset, sudden versus insidious, and progression of primary problem. Anything that worsens or improves condition, such as positions, rest, or medications. Review the patient's history, occupational history, past occupational exposures, or diseases such as asbestos, silicosis, and pneumoconiosis. Present occupational exposure to antigens within the workplace, such as hypersensitivity, pneumonitis. Past medical history that would alter physical exam or treatment plans. For example, heart disease or long-term steroid use. Current medications that can mask, such as steroids, or alter, such as beta blockers or bronchodilators. Vital signs. So current medications that can mask vital signs would be steroids, and medications that could alter vital signs would include beta blockers or bronchodilators. Smoking habits. Smoking in pack years, number of packs per day, times number of years smoked. Alcohol consumption and street drugs. Functional and exertional activity level during periods of wellness as well as with present illness. Cough and sputum production. Record any changes from baseline because of present illness. Family history of pulmonary disease such as cystic fibrosis. Tests and measures. Vital signs. Go ahead and make this a slideshow. Okay, vital signs. Table for one for normal values. Temperature normal. Afebrile is 98.6. Core temperature increase indicates infection. Heart rate normal 60 to 100 beats per minute. Tachycardia is over 100 beats per minute, and bradycardia is under 60 beats per minute. Respiration rate in healthy individuals is 12 to 20 beats per minute. Tachypnea is a rate over 20 beats per minute. Apnea means no respirations. Rhythm is either regular or irregular. Amplitude to be shallow or deep. Oxygenation is usually between 98 to 100% is normal. And then blood pressure. So temperature, heart rate, respirations, and blood pressure. Observation, peripheral edema seen in gravity-dependent areas. In jugular venous distension indicates possible heart failure. Right ventricular hypertrophy and dilation are common sequelae to chronic lung disease. Body position, stabilizing the shoulder girdle. For example, sitting, hands placed on seat, arms extended, body leaning forward. Places the thorax in an inspiratory position and allows the additional recruitment of muscles for inspiration, such as the pectorals. Color, cyanosis. An acute sign of hypoxia is a bluish tinge to nail beds in the areas around the eyes and the mouth. Digital clubbing, a sign of chronic hypoxemia. Digital clubbing, a sign of chronic hypoxemia. The configuration of the distal phalanx of fingers or toes become bulbous. Normal values for infants and adults. Heart rate, infant 120, adult 60 to 100. Blood pressure, 75/50, 120/80. Used to be 120/60, 120/80. Respiratory rate, 40 breaths per minute, and adult is 12 to 20 breaths per minute. I think the previous slide I said beats per minute. It should be breaths per minute. Oxygen, infant 75 to 80, adult 80 to 100. CO2, 34 to 54, adult 35 to 45. pH, 7.26 to 7.41, adult 7.35 to 7.45. Tidal volume, 20 milliliters, adult 500 milliliters. Inspection and palpation. Standard precautions should be used when a therapist may come in contact with a patient's body fluid. See box 1. Gloves are usually all that is needed during a routine physical exam. Neck. Observe the trachea. It should be in midline superior to the suprasternal notch. Note the use of accessory muscles of ventilation. Thorax. Changes in bony thorax. Pectus excavatum and carinatum. Observe anterior posterolateral dimension. In health, there is a 1-to-2 ratio. With obstructive pulmonary disease, the lung recoil force is decreased, resulting in a barreled chest and an increase in the anterior-posterior dimension. The right and left thorax should be symmetrical. Symmetry, static and/or dynamic, may be altered by changes in the bony thorax, scoliosis, scapular immobility, and pain. Changes in the underlying lung and pleura, a patient with pleuric pain or pneumothorax, or changes in the overlying skin, such as a thoracic burn. Thoracic excursion in healthy adults, measured at the base of the lungs from full inspiration to the end tidal volume expiration, is between 2 to 3 inches. Thoracic excursion in health, measured at the base of the lungs from full inspiration to full expiration, is 2 to 3 inches. Inspect for scars indicating potential adhesions to underlying soft tissue or surgical removal of structures within the thorax. Auscultation. Intensity of inspiration and expiration is quieter at the bases than the apex. Vesicular, normal breath sound. A soft rustling sound heard throughout all of inspiration and the beginning of expiration. Bronchial, a more hollow, echoing sound normally found only over the right superior anterior thorax. for the right superior anterior thorax, which corresponds to the area over the right main stem bronchus. All of inspiration and most of expiration are heard with bronchial breath sounds. Decreased, a very distant sound not normally heard over a healthy thorax, allows only some of the inspiration to be heard, often associated with obstructive lung diseases. Adventitious, extra sounds. According to the American Thoracic Society, there are only two adventitious breath sounds. The first one is crackles, also termed rails or crepitations. The crackling sound heard usually during inspiration that indicates pathology, atelectasis, fibrosis, pulmonary edema, heard during inspiration. Wheezes, a musically pitched sound usually heard during expiration, caused by airway obstruction such as asthma, chronic obstructive pulmonary disease, foreign body aspiration. With severe airway constriction such as croup, wheezes may be heard on inspiration as well. Vocal sounds, normal transmission of vocal sounds. As with breath sounds, vocal transmission is loudest near the trachea and main stem bronchi. Words would be intelligible, though softer and less clear, at the more distal areas of the lungs. Abnormal transmission of vocal sounds may be heard through fluid-filled areas of consolidation, capitation lesions, or pleural effusions. Egophony is a nasal or bleating sound heard during auscultation. E sounds are transmitted to sound like A. Bronchophony, characterized by an intense, clear sound during auscultation, even at the lung bases. Whispered pectoriloquy occurs when whispered sounds are heard clearly during auscultation. Radiographic examination, chest X-ray. Two-dimensional radiographic film to detect a presence of abnormal material such as exudate or blood, or a change in pulmonary parenchyma, fibrosis, or collapse. CT scan, computer-generated picture of a cross-sectional plane of the body. MRI, see figure 4.3. Ventilation perfusion, V/Q scan, matches the ventilation pattern of the lung to the perfusion pattern to identify the presence of pulmonary emboli. Fluoroscopy, continuous X-ray beam allows observation and diaphragmatic excursion. Laboratory tests, see table 1 through 4 for normal values. Arterial blood gas analysis indicates the adequacy of valvular ventilation by determining pH, biocarbonate ion, and partial pressure of carbon dioxide. Table 4.2 presents the 4 basic conditions of acid-base balance and the PaCO2, pH, and HCO3 values that accompany each condition. Arterial oxidation by determining the partial pressure of oxygen in relation to the fraction of inspired oxygen. Electrocardiogram, see Chapter 3, Cardiovascular Physical Therapy for discussion. Sputum studies, gram stain, immediate identification of the category of bacteria, gram-negative or gram-positive, and its appearance, for example, pairs or chains. Culture and sensitivity identifies the specific bacteria as well as the organism's susceptibility to various antibiotics, results available within a few days. Cytology reports the presence of cancer cells in sputum. Pulmonary function tests, PFTs, evaluate lung volumes, capacities, and flow rates, used to diagnose disease, monitor progression, and determine the benefits of medical management. See Figure 4.4 for changes in disease states. See Table 4.3 for classification of obstructive lung disease according to the Global Initiative for Obstructive Lung Disease, GOLD, including functional pulmonary function test values for each level of disease severity. Blood values. White blood cell count normal values are 4,000 to 11,000. Hematocrit normal values are 35% to 48%. Hemoglobin normal values are 12 to 16. Bronchoscopy, endoscope used to view, biopsy, wash, suction, and or brush the interior aspects of a tracheobronchial tree. Exercise tolerance test, ETT, graded exercise test. See also Chapter 3, cardiovascular physical therapy. Evaluates an individual's cardiopulmonary response to gradually increasing exercise. Determines the presence of exercise-induced bronchospasm by testing pulmonary function, particularly FEV1, before and after exercise tolerance test. Documents the need for supplemental oxygen during an exercise program by analyzing arterial blood gas values throughout the exercise tolerance test. ABGs also provide a criterion for test termination. If arterial blood sampling is unavailable, pulse oximetry can be used to monitor the percent saturation of oxygen within the arterial blood. Table 4.4 presents criteria for test termination for patients with pulmonary disease. See Chapter 3 Appendix, Selected Outcome Measures for Cardiac and Pulmonary Dysfunction. This is Figure 4.3, coronal T1 MRI thoracic view of a normal female. Table 4.2, interpretation of abnormal acid-base balance. Respiratory alkalosis, increased pH. Respiratory acidosis, decreased pH. Metabolic alkalosis, increased pH. Metabolic acidosis, decreased pH. So whether it's respiratory or metabolic, alkalosis is increased pH. Acidosis is decreased pH. PaCO2 with respiratory alkalosis is decreased. With respiratory acidosis, it is increased. So with respiratory alkalosis and acidosis, there is an inverse relationship between pH and PaCO2. With metabolic alkalosis and acidosis, PaCO2 is within normal limits. And as you see with HCO3, it's just the opposite. So there is a correlation between, with metabolic alkalosis, the pH and the HCO3 go up. metabolic acidosis, the pH and the HCO3 go down. So inverse relationship between pH and PaCO2 with respiratory conditions, and then the metabolic conditions, the pH and the HCO3, they either both go up or both go down. Causes. What causes respiratory alkalosis is alveolar hyperventilation. Alveolar hyperventilation. Increased pH. Hyperventilation. Decreased pH. Acidosis. Hypoventilation. The signs and symptoms of respiratory alkalosis is dizziness, syncope, tingling, numbness, early tetany. With respiratory acidosis, early signs are anxiety, restlessness, dyspnea, and headache. Late signs and symptoms include confusion, somnolence, I don't know what that means, we'll look it up, and coma. With metabolic alkalosis, the causes can be a bicarbonate indigestion, vomiting, diuretics, steroids, and adrenal disease. Vague symptoms include weakness, mental dullness, and possibly early tetany. With metabolic acidosis, causes can be diabetic, lactic, or uremic acidosis, prolonged diarrhea. Secondary signs and symptoms can be secondary hyperventilation, questionable breathing, nausea, lethargy, and coma. So let's go and look some vocabulary words up. Pause. Please hold. Okay, so tetany is a condition marked by intermittent muscular spasms caused by malfunction of the parathyroid glands and a consequent deficiency of calcium. So with respiratory alkalosis, signs and symptoms are dizziness, syncope, tingling, numbness, and early tetany. So intermittent muscle spasms caused by a malfunction of the parathyroid glands and a consequent deficiency of calcium. Somnolent basically means sleepy or drowsy. So respiratory acidosis, early signs is anxiety, restlessness, difficulty breathing, and headache. Late signs is confusion, sleepiness, drowsy, or coma. Lung volumes of a healthy pulmonary system compared with lung volumes and capacities found in restrictive and obstructive pulmonary disease. Interesting. So with normal, you have your tidal volume. Boy, this needs a little bit of analyzation. Let's come back to that. Okay. Graded exercise test termination criteria. Maximal shortness of breath, a fall in PaO2 of greater than 20 or PaO2 less than 55. A rise in PaCO2 of greater than 10 or PaCO2 greater than 65. So PaO2, 20, 55. Greater than 20, less than 55. Greater than 10 or greater than 65. That's basically memorization right there. Graded exercise test termination criteria. Cardiac ischemia or arrhythmias, systems of fatigue, an increase in diastolic blood pressure readings of 20, systolic hypertension greater than 250, and decrease in blood pressure with increasing workloads. Leg pain, total fatigue, signs of insufficient cardiac output, reaching a ventilatory maximum. O2, greater than 20, less than 55. CO2, greater than 10 or greater than 65. That doesn't make sense. Okay. Classification of obstructive lung disease outlined by the GOLD, Global Initiative for Obstructive Lung Disease, with the addition of functional abilities that correspond. Mild, FEV1 over FVC ratio, 70%. FEV1 is greater than 80% predicted, with or without chronic symptoms. Individuals may be unaware that lung function is abnormal. Moderate, less than 70%, 50%, greater than FE1, less than 80% predicted. I don't understand any of that. With or without chronic symptoms, individuals typically seek medical attention because of chronic respiratory symptoms or an exacerbation of their disease. Severe, I'm going to look for a video to help me understand. Okay, so this is going to require some more analyzation. Let's bring these two down. That one down. Let's bring this one down. That one is kind of self-explanatory, sort of. These two, I don't really get that much. I don't understand those two. Do you understand those two? I don't understand. And let's do it again. Because these are both that I need to come back and look at again. Because I don't get either one of those two. What are we here? That one's not too bad. And these two. Okay. And then more therapy ed. Let's just come on. We're going to come back to those two. Physical therapy intervention. Manual secretion removal techniques. Postural drainage. Placing the patient in varying positions for optimal gravity drainage of secretions and increased expansion of the involved segment. See Figure 4.5. Indications for use of postural drainage. Increased pulmonary secretions, aspiration, ectalepsis, or collapse. Considerations prior to use of postural drainage position. See Table 4.5. These considerations are not intended to imply absolute danger, but rather a possible need for position modification. Procedure. Explain the procedure to the patient. Place the patient in appropriate postural drainage position. Observe for signs of intolerance. Duration of procedure can be up to 20 minutes per postural drainage position. Typically, duration equals the duration of other manual techniques used in conjunction with postural drainage. Percussion. A force rhythmically applied with the therapist's cupped hands to a specific area of the chest wall that corresponds to the involved lung segment. Percussion is used to increase the amount of secretions cleared from the tracheobronchial tree, usually used in conjunction with postural drainage. Indications for use of percussions include excessive pulmonary secretions, aspiration, atelectasis, or collapse due to mucus plugging, obstructing the airways. Considerations to weigh possible benefits of percussion against possible deterrents prior to the application of this technique are listed in Table 4.6. Modification of the technique may be necessary for patient tolerance. Procedure. Explain the procedure to the patient. Place patient in appropriate postural drainage position. Cover the area to be percussed with a lightweight cloth to avoid urethemia. Percuss over area of thorax that corresponds to the involved lung segment. The duration of percussion depends on the patient's needs and tolerance. 3 to 5 minutes of percussion per postural drainage position with clinically assessed improvement is a guideline. The force of percussion causes the patient's voice to quiver. Shaking vibration. Following a deep inhalation, a bouncing maneuver is applied to the ribcage throughout exhalation to hasten the removal of secretions from the tracheobronchial tree. Commonly used following percussion in the appropriate postural drainage position. Modification may be necessary for patient tolerance. Indications for the use of shaking: excessive pulmonary secretions, aspiration, atelectasis, or collapse of an airway from mucus plugging. Considerations prior to the application of shaking are similar to those of percussion. See Table 4.6. Procedure. Explain procedure to the patient. Place patient in appropriate postural drainage position. As patient exhales, the patient's hands provide a jarring, bouncing motion to the ribcage below. The duration of shaking depends on the patient's needs, tolerance, and clinical improvement. 5 to 10 deep inhalations with the shaking technique is generally acceptable practice. Any more than 10 would risk hyperventilation, increased VE. I think that's minute ventilation, resulting in decreased PaCO2, and less than 5 may be ineffective. Perform percussion if appropriate. Where does this go? What's going on here? Okay. 1, 2, 3, 4, 5. Oh, okay. Okay, I get it. Oops. So E, procedure. Explain procedures to the patient. Place patient in appropriate postural drainage position. Perform percussion if appropriate. As patient inhales deeply, the therapist's hands are placed with fingers parallel to the ribs. That's E. And then go up here, 5. As the patient exhales, the therapist's hands provide jarring. Let's do this. That way. Okay, so these are the postural drainage positions, and I have already gone over that in part 2 in detail, so we will not do that again. Considerations prior to the use of postural drainage. Precautions to the use of Trendelenburg position, head of bed tip down 15 to 18 degrees. Circulatory system, pulmonary edema, congestive heart failure, hypertension. Abdominal problems, obesity, ascites, pregnancy, hiatal hernia, nausea, vomiting, recent food consumption. Neurological system, recent neurosurgery, increased intracranial pressure, aneurysm precautions. Pulmonary system, shortness of breath. Precautions to the use of side-lying position. Circulatory system, axial femoral bypass graft. Musculoskeletal system, humeral fractures, need for hip abduction brace. Other situations that make side-lying uncomfortable, such as arthritis and shoulder bursitis. I want to do another vocabulary word lookup, so please hold. Okay, ascites is the accumulation of fluid in the peritoneal cavity causing abdominal swelling. So that would be a precaution. Ascites. 6. Considerations prior to the use of percussion and shaking. General guidelines, pain made worse by the technique. Circulatory system, aneurysm precautions, hemolysis, coagulation disorders such as increased partial thromboplastin (PTT) time, increased prothrombo-time (PT), decreased platelet count below 50,000, or medications that interfere with coagulation. Musculoskeletal system, fractured rib, fail, chest, degenerative bone disease, and bone metastasis. Airway clearance techniques. Cough. Patients should be asked to cough in an upright sitting position if possible after each area of lung has been treated. Coughing clears secretions from the major central airways. Huffing. A more effective in patients with collapsible airways, chronic obstructive diseases. Prevents the high intrathoracic pressure that causes premature airway closure. Ask patient to inhale deeply. Immediately, the patient forcibly exhales the air, saying, ha, 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 ha. Assisted cough. The therapist's hands or fist become the force behind the patient's exhaled air. Used when the patient's abdominal muscles cannot generate an effective cough, such as spinal cord injury. The amount of force by the therapist depends on patient tolerance and abdominal sensation. Position the patient against a solid surface, supine with head of bed, flat or in Trendelenburg position, or sitting with wheelchair against the wall or against the therapist. The therapist's hand is placed below the patient's subcostal angle, similar to hand placement for the Heimlich maneuver. Patient inhales deeply. As the patient attempts to cough, the therapist's hand pushes inward and upward, assisting the rapid exhalation of air. Any secretions raised should be removed by the suction catheter if expiration is problematic. And it goes on and on and on. So bored with it. Okay. Tracheal stimulation used with patients who are unable to cough on command, such as infants or patients with brain injury or stroke. The therapist's finger or thumb is placed just above the suprasternal notch, and a quick inward and downward pressure on the trachea elicits the cough reflex. Endotracheal suctioning, used only when the above airway clearance techniques fail to adequately remove secretions. Standard precautions are employed since contact with the patient's bodily fluid is expected. Equipment: suction catheters comes in sizes of 14 French gauge, usually for an adult, 10 for older children, 8 to 5 for young children and infants. Suctioning system set at approximately 120 mmHg of suction. Sterile glove, clean glove. Procedure: a catheter is fed through either an artificial airway, oral airway, or the nares through the pharynx, larynx, or to the carina. When resistance is felt at the carina, the catheter is rotated and withdrawn. Suction is applied intermittently so as not to damage the inner lining of the trachea. The usual suctioning time is 10 to 15 seconds. Complications associated with suctioning: hypoxemia, bradycardia or tachycardia, hypotension or hypertension, increased intracranial pressure, epilepsy, brachial damage, and infections. Independent secretion removal techniques. Is this not respiratory therapist stuff? I don't remember learning any of this in cardiopulmonary class. But anyway, let's finish it. Let's get this over with. Oh, we got 8 more slides. I'm sorry for my commentary, but this is so boring. Independent secretion removal techniques. Active cycle of breathing. An independent program to assist in the removal of more peripheral secretions that coughing may not clear. Breathe in a controlled diaphragmatic fashion. Perform thoracic expansion exercises with or without percussion and shaking. These are deep inhalations with a hold at the top if possible. Controlled diaphragmatic breathing. The patient decides what is needed next. If no secretions seem to be mobilized, the patient returns to step B, then C, and reassesses the situation. B is breathe in a controlled diaphragmatic fashion, and C is perform thoracic expansion exercises with or without percussion and shaking. These are deep inhalations with a hold at the top if possible. If the patient believes secretions can be cleared, the patient moves on to steps E and F. Inhale at a resting tidal volume. Contract the abdominal muscles to produce 1 or 2 forced expiratory huffs from mid to low lung volume to raise secretions. Huff from high lung volume or cough to clear. Controlled diaphragmatic breathing. Repeat these cycles until secretions are in large airways. That is active cycle of breathing. Autogenic drainage. An independent program used to sense peripheral secretions and clear them from the tracheobronchial irritation from coughing. The amount of time spent in each of the following phases is determined by where the patient feels the secretions. Unstick phase. Quiet breathing at low lung volumes to effect peripheral secretions. Collect phase. Breathing at mid-lung volumes to affect secretions in the middle airways. Evacuation phase. Breathing from mid to high lung volumes to clear secretions from central airways. Replaces coughing as the means to clear secretions. Repeat the steps corresponding to the area of retained secretions until all secretions are removed from the airways. Flutter or a cappella device. A patient uses an external device that vibrates the airways on exhalation to improve airway clearance with intermittent positive expiratory pressure. The patient breathes in a normal tidal volume through the nose or around the mouthpiece of the flutter device. The patient then exhales through the device, setting up a vibration within the airways. Experimentation in the tipped position of the device may provide the most vibration possible with exhalation. Repeat 5 to 10 times. Patient then breathes in a full inhalation through the nose and around the mouthpiece. This is followed by a 3-second hold at the top of the inhalation and rapid forced exhalations through the flutter device. Repeat 2 to 3 times. Huff or cough to clear secretions. Repeat steps A through H until all secretions are removed from the airways. Low pressure positive expiratory pressure. Keep mask. The patient uses positive expiratory resistance via face mask to help remove airway secretions. Low pressure PEP measures 10 to 20 centimeters of water, H2O. Seated patient breathes at tidal volumes with mask in place. After approximately 10 breaths, the mask is removed for coughing or huffing to clear secretions. The sequence is repeated until all secretions are removed from the airways. High pressure positive expiratory pressure PEEP mask. So you have low pressure and high pressure. With high pressure, the patient with an unstable airway uses high expiratory pressure via face mask to assist in removal of airway secretions. High pressure PEEP uses the point of PEEP between 50 to 120 centimeters of water, where the patient is able to exhale a larger FVC with the mask than without. Seated patient breathes at tidal volumes with mask in place. After approximately 10 breaths, huffing from high to low lung volumes is performed with the mask in place. The sequence is repeated until all secretions are removed from the airways. High-frequency chest wall oscillation. Patient wears a vest that fills with air and then rapidly increases and decreases pressure. Pressure oscillation loosens secretions in the airway. Settings. Frequency is set to 12 to 15 Hertz, 12 to 16 Hertz, and pressure is inflated until snug on patient. Time, 20 to 30 minutes with breaks to cough and drink water as needed. Can be completed in postural drainage positions. Diaphragmatic breathing, used to increase ventilation, improve gas exchange, decrease work of breathing, facilitate relaxation, and maintain or improve mobility of chest wall. Used with post-operative patients, post-traumatic, post-trauma patients, patients with obstructive or restrictive pulmonary lung diseases. Procedure. Explain procedure to patient. Position patient in semi-reclined, semi-Fowler's position. Place therapist's hand gently over a subcostal angle of the thorax. Apply gentle pressure throughout the exhalation phase. Increase to firm pressure at the end of exhalation. Ask patient to inhale against resistance of the therapist's hand. Release pressure, allowing for full inhalation. Progress to independence of therapist's hand in upright sitting, standing, walking, and stair climbing. I gotta take a break before I pull my hair out. Segmental breathing. Used to improve ventilation to hypoventilated lung segments. Alter regional distribution of gas. Maintain or restore functional residual capacity. Maintain or improve mobility of chest wall. And prevent pulmonary compromise. Used for patients with pleuritic, incisional, or post-trauma pain that causes decreased movement in the portion of the thorax, splinting, and those at risk for developing atelectasis. Inappropriate for intractable hypoventilation until medical situation is resolved. Palliative therapy to reduce bronchogenic tumor size or chest tube to reduce a pneumothorax. Procedure. Explain procedure to patient. Position patient to facilitate inhalation to a certain segment, such as postural drainage, positions, upright sitting. Apply gentle pressure to the thorax over area of hypoventilation during exhalation. Increase to firm pressure just prior to inspiration. Ask patient to breathe in against the resistance of therapist's hands. Release resistance, allowing for full inhalation. Sustained maximal inspiration. Used to increase inhaled volume, sustain or improve alveolar inflation, and maintain or restore functional residual capacity. Used in acute situations, patients with post-trauma pain, post-operative pain, acute lobar collapse. Acute lobar collapse. Procedure. Inspire slowly through the nose or pursed lips to maximal inspiration. Hold maximal inspiration for 3 seconds. Passively exhale the volume. Incentive spirometers, devices used to measure and encourage deep inspirations, can help patients achieve maximal inspiration during sustained maximal inspiration. Pursed lip breathing. Used to reduce respiratory rate, increase tidal volume, reduce dyspnea, decrease mechanical disadvantages of impaired ventilatory pump, improve gas mixing at rest for patients with COPD, and facilitate relaxation. Primary use for patients with obstructive disease who experience difficulty breathing at rest, or with minimal activity, exercise, or with ineffective breathing patterns during activity and exercise. Procedure. Slowly inhale through the nose or mouth. Passively exhale through pursed lips, position mouth as if blowing out candles. Additional hand pressure from the therapist applied to the abdomen can gently prolong expiration. Abdominal muscle contraction can be used to increase exhale volume. Care must be taken not to increase intrathoracic pressure, which may cause airway collapse. Abdominal strengthening. Used when abdominal muscles are too weak to provide an effective cough. Abdominal splinting. Used when abdominal muscles cannot provide the necessary support needed for passive exhalation. For example, in high thoracic and cervical spinal cord injuries. It is important to ensure that the binder does not restrict inspiration. Glossopharyngeal breathing, air gulping, can also be taught to assist coughing. Okay. I want to see if I can find some videos on that to help with that. So, please hold again. Okay, let's watch this video and see if this helps at all.
Hi, my name is Hamza Reyes. I'm a critical care fellow at Mayo Clinic Rochester. Over the next 5 minutes, I'll be talking about the updated 2017 Global Initiative for Chronic Obstructive Lung Disease. COPD is one of the leading causes of death in the United States. Over 3 million people died of COPD in 2012, accounting for 6% of all deaths globally. And these numbers are going up every year. Therefore, it's very important to not only promptly diagnose these patients, but also differentiate between different disease severities so that appropriate therapeutic modalities can be used to help those patients. And here comes the rule of Goal 2017, which in addition to grading COPD to grade 1 to 4 based on spirometry measurements, but also further classifies it into A, B, C, D grouping based exclusively on patient symptoms and functional status. I like to compare FEV1 with air resistance on a speeding car. This Formula One performance depends for sure on aerodynamics. However, whatever airway resistance is there, even if the front was completely squared, wouldn't stop it from advancing, which tells us there are other variables to take into consideration, including the strength of the engine, condition of tires, how much gas it has left on it, and whether the body of the car is still in shape or not. Similarly, when we were speaking about the lungs, spirometry helps grade the severity of COPD to some extent. But there are other factors that significantly contribute to overall disease severity, like comorbidities, overall general health, number of exacerbations, and admissions the patient had to the hospital. Therefore, it's really more than spirometry measurements, which is the reason for the new Goal 2017 grouping classification, which looks at the patient's current magnitude of symptoms, functional status, exacerbations, and admissions to the hospital. So when you have a clinical diagnosis of COPD and confirmed obstructive airway disease on a pulmonary function test, check also for history of exacerbations and admissions related to exacerbation. If your patient had 1 or no admissions to the hospital, and this is likely a relatively mild form of COPD. But if your patient had 2 or more exacerbations and any number of admissions, then this is likely a relatively more severe form of COPD. But as you can see, this is too broad. We need to be more specific. So let's further break it down into A and B, depending on severity of shortness of breath using the modified Medical Research Council scoring system and using the functional status of the patient.
Okay, that looks more than what we need. So let's hold. I enjoyed his accent though. Okay, I found a video. It's kind of long, but I'm going to put this on this video anyway, because when I go back to study it, I want to know this better. So, here we go.
We continue our playlist called Pulmonology or Pulmonary Medicine or Respiratory Medicine. And in the previous video, we started talking about the pulmonary function test. Today, we continue on talking about FEV1 to FVC ratio, how we use it to differentiate between normal obstructive lung disease and restrictive lung disease. The patient inhaled from the spirometer, and then we ask him to actually inhale maximally and then exhale maximally and quickly. This is the FVC. We measure what percentage of the volume came in the first second, and we get this ratio, and it helps us big time clinically. With that being said, now let's get started. In the previous video, I've told you the difference between vital capacity and forced vital capacity. Forced vital capacity, which is today's topic, is timed. It has a lower value if compared to vital capacity because it's timed. We ask the patient to actually inhale rapidly and exhale rapidly, so it takes less time That's why it has a lower value. In vital capacity, it's not time. The patient has its time to inhale. So it has a higher value because there is more volume involved. Don't confuse FVC with FRC. Okay, Mr. John, please inhale and exhale maximally and quickly. This is called FVC. We measure out of this FVC how much volume came out during the first second, and this is called FEV1, 1 for 1 second. FVC stands for forced vital capacity. This stands for forced expiratory volume on the first second, in the first second. Okay. Normally, it should have a 4 to 5 ratio, which happens to be equals 80.
Okay, so FEV1 is the amount of air that you can quickly and forcibly exhale in 1 second after maximal inhalation. So FEV1 is the amount of air that you can quickly and forcibly exhale in 1 second after maximal inhalation. FVC is the amount of air that you can quickly and forcibly exhale after maximal inhalation. So FEV1 is in 1 second, and FVC is the total amount of air that you can quickly and forcibly exhale after maximal inhalation. So FEV1 is timed the amount of air that you can quickly and forcibly exhale in 1 second after you maximally inhale. FVC is the amount of air that you can quickly and forcibly exhale after maximal inhalation. So they're both timed, but the first one is in 1 second. So FEV1 divided by FVC ratio. Normally it's 80%. So if you go over here to mild, moderate, severe, and very severe, it's all below 70%. So now we need to know what this column means, FEV1. We'll see if this video tells us that.
So normally, FEV1 to FVC ratio equals 80%. Let's talk about obstructive lung disease. What is the definition? I cannot get the air out. Example, emphysema. If I cannot get the air out, I will have a barrel chest because I have increased residual volume and therefore increased total lung capacity. FEV1 is reduced. No kidding, because there is reduction of my ability to get the air out. That's why they have wheezing. FVC is also reduced. Absolutely, same concept. But FEV1 to FVC ratio is reduced because that reduction in FEV1 is greater than the reduction in FVC. So here is FEV1 over FVC. If you reduce this more than the denominator, the result is decrease in the FEV1 to FVC ratio. And this is an obstructive lung disease. Why? Because the effect is greater in the first second. It's like this. I cannot get the air out. So instead of the FEV1 being 80% of the FVC, now it's about 60% or 50% or 30% because I couldn't get air during the first second. So if the normal ratio FEV1 to FVC was 4 liters over 5 liters equals 80%, in cases of obstructive lung disease, it's about 2.4 liters over 4 liters, which happens to be 60%, or less, could be less. So to diagnose an obstructive lung disease, you need 2 steps. Number 1, you calculate the FEV1 to FVC ratio and it's gonna be less than 70%. That's the definition of an obstructive lung disease. Why? I cannot get the air out, especially in the first second. Then, to determine the severity of the obstructive lung disease, you might have a patient with mild emphysema. You might have a patient with severe emphysema. What is the difference? Now you look at the FEV1 alone, not the FEV1 FVC ratio, but the FEV1 alone to determine the severity. The lower the ratio, the greater the severity, the more severe the case. So, if patient A has FEV1 of 2.4 liters and patient B has FEV1 of 1.9 liters, which one has a more severe obstructive lung disease? And the answer is patient B. That was obstructive lung disease. Now let's talk about restrictive lung disease. What is the definition? Restrictive lung disease. My lungs are restricted from filling. I cannot get the air in, not out. Example, lung fibrosis. If I cannot get the air in, therefore there is less air coming out because I had less air coming in to begin with. So what's happening to FEV1? Decrease. How about FVC? Also decrease. The lung is not normal. But if you have FEV1 here and FVC here, the reduction in FVC was greater than the reduction in FEV1, leading to an increased FEV1 to FVC ratio, or it could be normal at best. So instead of getting 5 liters out, called FVC, I only got 4 liters. But during the first second, I got 3.5 liters out, which happens to be 88%. The ratio is higher than normal. Why? Because your lung is fibrosed. Translation, it has a lower compliance but an increased elastic recoil. Okay, it's very hard to get the air in, but it's easy to get the air out. Why? I have very, very strong fibers. That's why the FEV1 has a greater ratio as a percentage of the FVC. So, to diagnose a restrictive lung disease such as lung fibrosis, step number 1, check the FEV1 FVC ratio. It's going to be normal or increased. Then, check all of the volumes, FEV1, FVC, TLC, RV, FRC, SVC, they are all decreased. I'm sorry, this is FVC. Okay, they are all decreased. Why? Because my lung is restricted from filling. I have less air coming into my lung, and therefore I will have less air coming out of my lungs. It's called common sense. Now here is a very good question. Let's say that you have an FEV1 to FVC ratio and it was normal. We have 2 probabilities. Number 1, it's a normal person, or it's a patient with a restrictive lung disease. Both of them can have a normal ratio. How to tell which is which? First, you look at the FEV1 and FVC alone without the ratio. So the FEV1 is going to be lower, that's a restrictive lung disease. FVC is also going to be lower, that's a restrictive lung disease. But if the subject is normal, FEV1 is normal, FVC is normal, FEV1 to FVC ratio is normal. But if the patient had a restrictive lung disease such as a pulmonary fibrosis, he will have decreased FEV1, decreased FVC, normal FEV1 to FVC ratio. Or of course it could be increased. And also check all of the lung volumes. How to determine the severity of a restrictive lung disease? Check the TLC. The lower the TLC, the greater the severity. Now, students hate these graphs, but they are actually very easy. This is not calculus, this is not astrophysics, this is like 5th grade stuff. So here is FEV1, here is FVC, here is 4 liters, 5 liters. Can you get the ratio? Yes. 4 divided by 5 is 80%. Excellent. Let's do it with obstructive lung disease. FEV1 is 2.4 liters, FVC is 4. 2.4 over 4 is about 60%, which happens to be decreased, less than 80%. Restrictive lung disease, 3.5 over 4. 3.5 over 4 is 88%. Can you comment? Yes, in normal people, FEV1 FVC ratio is normal. In obstructive lung disease, it's decreased. In restrictive lung disease, it's increased. Or it could be normal. If you really don't want to think, here is a very great mnemonic. Obstructive lung disease obscures the ratio, decreases. Restrictive lung disease raises the ratio or at least remains constant. Let's dig deeper into obstructive lung disease such as emphysema, which is a COPD, chronic obstructive.
Very interesting. Okay, let me go ahead. I'm going to pause this again.
Now, students hate these graphs, but they are actually very easy. This is not calculus, this is not astrophysics, this is like 5th grade stuff. So here is FEV1, here is FVC, here is 4 liters, 5 liters. Can you get the ratio? Yes. 4 divided by 5 is 80%. Excellent. Let's do it with obstructive lung disease. FEV1 is 2.4 liters, FVC is 4. 2.4 over 4 is about 60%, which happens to be decreased, less than 80%. Restrictive lung disease, 3.5 over 4. 3.5 over 4 is 88%. Can you comment? Yes, in normal people, FEV1 FVC ratio is normal. In obstructive lung disease, it's decreased. In restrictive lung disease, it's increased. Or it could be normal. If you really don't want to think, here is a very great mnemonic. Obstructive lung disease obscures the ratio, decreases. Restrictive lung disease raises the ratio or at least remains constant. Let's dig deeper into obstructive lung disease such as emphysema, which is a COPD, chronic obstructive pulmonary disease. The patient cannot get the air out, leading to air trapping. That's why the patient has a barrel chest. This has decreased elastic recoil because you have destroyed all of the elastin fibers.
Okay, so you can put the website down here if you want to go back and watch that entire video, but for our purposes here, that video really did help to explain mild, moderate, severe, and very severe. So FEV1 is the amount of air that you can quickly and forcibly exhale in 1 second after maximal inhalation. For mild obstructive lung disease, it's going to be more than the 80% productive. With moderate, it's going to be between 50 and 80%. With severe, it's going to be between 30 and 50%. And with very severe, it's going to be less than 30% or less than 50% with chronic respiratory failure symptoms. So FEV1, mild 80%, moderate 80 to 50%, severe 50 to 30%, and very severe less than 30, unless it's chronic respiratory failure symptoms. And unless you have chronic respiratory failure symptoms, and then it's just less than 50%. So symptoms of mild, moderate, and severe with or without chronic symptoms for first, second, and third. Mild, moderate, severe, and when very severe, PaO2 less than 60 and PaCO2 more than 50. And core I don't know what that means. So, of course, we gotta pause and go find out what it means. Okay, so, with a mild disease, individuals may be unaware that lung function is abnormal. With moderate, they may seek medical attention because of chronic respiratory symptoms or an exacerbation of their disease. With severe, they experience greater shortness of breath, reduced exercise capacity, fatigue, and impact on quality of life. And with very severe, the quality of life is very appreciably impaired, and exacerbations may be life-threatening. So the measurement of actual oxygen content in arterial blood is less than 60, and the partial pressure of carbon dioxide in arterial blood is greater than 50, and core pulmonary abnormal enlargement of the right side of the heart as a result of disease of the lungs or the pulmonary blood vessels. Abnormal enlargement of the right side of the heart as a result of disease in the lungs or pulmonary vessels. Okay, so we went on that over that already. This one, now this one. Lung volumes of a healthy pulmonary system compare with lung volumes and capacities found in restrictive and obstructive pulmonary disease. So I think I might just do another video just on that slide alone. Because I'm going to go get ready for kickboxing, and this is already an hour and 15 minutes. So we're going to stop it.